Thank you. So this basically today we are having a cardiovascular health focus and really being led by the Global Cardiovascular Health Program, which is part of UW. So if the agenda for today, we'll go through the introduction to the Global Cardiovascular Health Program. So I will lead that briefly, and then we will have a presentation by Floria, who is an MPH student from the Cardiometabolic Training Program, Research and Training Program, CMRTP, on lifetime cardiovascular disease risk prediction among women with hypertensive disorders of pregnancy. And then we'll have Dr. Saate Shakil talking about early structural heart disease, HIV and TB in East Africa, the Asante study. And then Dr. Fitzpatrick looking at cardiometabolic research and training programs. So welcome everyone. We really are going to, I'm hoping we'll have a good time today. So just as a guide, we'll have 15 minutes presentation for each of, for Saate and Floria, and then we'll have a few minutes with Annette, and then we'll have a Q&A. So we'll just go straight into it because of, to just make sure that we are on time. So the Global Cardiovascular Health Program really was established in November 2021. And it's really, I don't know if you have heard about it, but this is an opportunity for you to hear about it. It is in the University of Washington, and really a joint effort between the Department of Global Health and the Division of Cardiology. So the program is led by our director, Dr. Chris Longenecker, and part of the core faculty and staff is myself. We have Dr. Yangfang, Su, and Alicia. So that's our team here. In terms of our plan and our strategy for the next 3 years, is really our vision is to achieve optimal cardiovascular health. So we really want to see that, and we are looking at this globally, a world where individuals can achieve optimal cardiovascular health. And our mission really is to drive improved outcomes. And we want to do this through one, interdisciplinary research, education, equitable partnerships and collaborations and mutual respect. So you will see that in the slides and in what we are trying to really work on as a program to build interdisciplinary research and training. So we have 4 levers that we are looking at. One is building interdisciplinary research program. And we have several focus areas, intersection of cardiovascular disease with infectious disease, hypertension, reciprocal innovation. So if you may have heard of reciprocal innovation, which we talk about bidirectional exchange and iteration of ideas, resources, innovations to address shared challenges across diverse settings. So not just from learning from the US to LMICs, but also LMICs to the US, and even in the US, global to rural. So looking at these various facets in terms of always learning from each other. And today is our opportunity to keep on learning from each other. Our second lever is around expanding UW education programs. We want to continue to build faculty pipeline who are working on cardiovascular research and also being able to participate in the programs, and partnering with partner institutions as well as the Global Fellows Program, which is in partnership with the cardiology department. We also have training and capacity building opportunities, really focusing on several methods, and also looking at grant writing and peer-to-peer learning. So part of what we'll be talking about today is the CMRTP program, which Floria is part of, which is really trying to build capacity in cardiovascular health. The last part is to develop an internal system and capacity. And we have our first advisory committee coming up in a few months, as well as building funding opportunities for the program and sustainability and building infrastructure. So we have, just in line with those levers, we have some outcomes. One is really to become a leader in global cardiovascular research, to attract, to be an attractive home for faculty and students for cardiovascular health, and building skills and capacity for partnerships. So you keep on hearing interdisciplinary training, research, and partnerships. And how do we do this in the last part? So we've talked about the what, and how do we really do this is really through each of us and our partnerships with various institutions and with countries. So our focus right now is on Africa, Latin America, and Asia, and not just everywhere, but specific countries like in Africa, in Kenya, Uganda, and Mozambique. In Latin America, Brazil and Peru. In Asia, it's Nepal and Vietnam. And really do this through faculty, so affiliated faculty who we are working with. For right now, we are about 40 projects globally in those 3 areas, and they have expertise in different disciplines, including cardiology, cardiac surgery, health system evaluation, health metrics, policy, epidemiology, and implementation science. And so what we are focusing is really on those methodologies and really partnering with several disciplines, but we've really focused on 3. Last month, we had a conference series with the School of Nursing, and we are planning the next one either with endocrinology or neurology. So really focusing on interdisciplinary research and how we can be able to work on this together. And also to promote that, the grant opportunities also focus on the same thing. So that was just a brief around the Global Cardiovascular Health Program. We have a website. You can be able to view the website and get more info. I want to pause there if there's any question, and also invite Chris if there's anything else you would want to add about the program.
No, you said it well.
Okay.
We'll put the link to the website in the chat.
Great. Thanks. Any question about the program? Okay. Great. Maybe we can proceed, and then we will come back to it. So I want to invite Floria Nyandaya. She's Kenyan. She's a first-year MPH student. She's also a Fogarty Fellow with the Cardiometabolic Research and Training Program at the university. She received a medical degree from the University of Nairobi. She's working in terms of, she's worked in influenza, chronic disease in Kenya. And today she will be sharing her research, which focuses on predicting cardiovascular disease risk among postpartum women, addressing obstetric cardiovascular surveillance gaps, and improving maternal outcomes. So her work really focuses on cardiovascular disease and maternal health. So I want to invite Floria to take us through. You have 15 minutes, and then we'll proceed to Saate. Welcome, Floria.
Thank you so much, Sarah, for the wonderful introduction. I appreciate the opportunity to be here and also just to share and talk about my research experience. So my research today, I just want to confirm, will I be able to control the slides, or it will be done for me?
Alicia's managing the slides right now for you.
Okay, that's fine. That's fine. Thank you. So my proposed thesis is looking at the lifetime cardiovascular disease risk prediction in postpartum women who have a history of hypertensive disorder of pregnancy in Nairobi, Kenya. So onto my slide outline, I'll just be taking you through the background, the significance, my aims. I'll also look at the methodology, the data analysis, as well as sample size, as well as the strengths and limitations, as well as my acknowledgements. So looking at the global landscape for cardiovascular disease in women, we are seeing that the burden of cases seems to be rising, as that is spread out throughout the globe, and that is predominantly in the Americas region, and also a bit of some countries within North America, and predominantly also in Asia. But just looking at the number of deaths, we can see that parts of Asia and also parts of Africa are disproportionately affected. And this is because when you look at all-cause mortality among women, 35% of these cases are attributed to cardiovascular disease, and actually 80% actually occur in low and middle income countries. So when we go on and looking at the global cardiovascular disease burden in Kenya, we can go to the next slide, please. we can see that across all females within the reproductive age, cardiovascular disease is actually among the top 10, and it's actually rising when you compare with 1990. And when you look at females who are above 50 years and even above 70 years, cardiovascular disease is an increasing burden in terms of the DALYs. And we can actually see, in as much as there was a downtrend from 1990 to 2019, we can see that even among the females who are 70 years, that it is still maintained. And so this maintains that cardiovascular disease is of a significant importance in some of these countries, and especially in Kenya. So when we go on the next slide, and even just looking at the SCVD or cardiovascular disease risk factors, the American Heart Association has been able to recognize some of these risk enhancing characteristics that tend to be sex specific, especially for women. So you have your preterm delivery, hypertensive disorders of pregnancy, gestational diabetes, among others that have been discovered. So in terms of focusing specifically on hypertensive disorders of pregnancy, which comprises what we call adverse pregnancy outcomes. It's a conciliation of 4 different syndromes or diseases that occur during pregnancy. We find that that hypertensive disorder of pregnancy is predominant even in Africa and also in Kenya, with a prevalence of up to 10%. And based on the ACOG definition, we have 4 syndromes. So you have your gestational hypertension, preeclampsia with or without severe features. So this means when it affects, for example, your renal system, and you also have HELP, which consists of hemolysis, elevated liver enzymes, low platelets, and also your eclampsia. So this is a diagnosis. So all these are diagnoses that occur after 20 weeks of gestation, but not persisting beyond 12 weeks of gestation. And we have seen that this is associated with hypertensive disorders of pregnancy are associated with a 3-fold risk of cardiovascular event. So on the next slide, we can be able to see that what usually happens, especially for these women who have hypertensive disorder of pregnancy, they are recommended to have routine visits. So within the first 3 weeks of giving birth, and at 12 weeks, just to be able to have like a full comprehensive checkup, and every year just to be able to evaluate the cardiovascular system. But you find that some of these women avoid or delay going to hospital. There's inadequate clinical follow-up, especially that period when they're transitioning from the obstetric aspect into, for example, the specialist clinics, or even into the medical clinic for routine follow-up. So it's sort of a vicious cycle. So we have a missed opportunity where we're not able to detect and also prevent some of these cardiovascular diseases much early. So when you look at some of these social determinants of health, we have this pre-existing suboptimal postpartum care. You find this have been complicated by what we call the social determinants of health. So if they're not able to access healthcare within the required period, and if it's within where they live, you also find this affects their access to some of these important services. Even routinely where they live can also impact where they are, because they might not have access to, for example, places where they can go to exercise, or even be in a place where that is not well, not polluted. Economic stability, because some of these women will have to decide, do they pay for healthcare, or do they try to put food on the table? And you also find social and community context where they are, sometimes they may not have the required social support to help them, and even just education access and quality. So if someone is not well educated and does not know how to take control of their health, they may not know that it is important for them to go to hospital as soon as possible to prevent some of these complications. So this brings me now to the next slide, where I'll be focusing on some of the cardiovascular risk assessment tools that we went through, that some of them have been developed and used in America as well as Europe, and also globally, focusing on a couple of cardiovascular risk factors. And so they are able to give either a 10 to 15-year cardiovascular risk as well as a lifetime risk. But because of our population, can go to the next slide, which we are focusing on a predominantly younger population, we chose to take the SCVD or the 2013 AHA or ACC risk tool, which is also known as the pool cohort equation. So this is able, so you can be able to do a 10-year cardiovascular risk score, as well as a lifetime. And we chose the lifetime because we, in our study, will predominantly have a younger population of above 30 years to around 40 years. And also if you are above 40 years, if you have a low risk score, in terms of the 10-year risk, you can also use it. And also its essence of giving an absolute risk is also very beneficial. And the fact that it was also derived from a large multi-ethnic prospective cohort compared to some of them that had predominance in, let's say, one population group compared to the other. So we want to see its performance in Kenya. So this brings me now to my aims. So my first aim will be to determine the lifetime risk of CVD or cardiovascular disease development using the pool cohort equations at 6 months postpartum for women with and without a history of HDP in Nairobi, Kenya. And my hypothesis is that postpartum women who had a history of HDP will have a higher lifetime CVD risk compared to women who had a normal pregnancy outcome. And for my second aim, I'm looking at the associations between the social determinants of health. So looking at education, income, neighborhood and built environment, as well as social and community context, and looking at now the changes in cardiovascular disease risk at baseline, 12 months and 24 months among these women with HDP. So specifically, I'll be focusing on blood pressure, body mass index, lipid profile, physical activity and diet. And my hypothesis is that women who have a lower education level, low income and healthy diet and living in rural and informal settlements will have a higher cardiovascular risk factor by then. So going on to just looking at the impact and the significance of this study, evaluating the cardiovascular risk, especially using the pool cohort equation, as well as looking at the association of social determinants of health with a longitudinal change in cardiovascular risk factors is very novel and significant, especially in a postpartum cohort with HDP, because most of the time, there are not many studies that have looked at a postpartum cohort and also looked at the changes in risk factors. We just use a time point, and also integrating the pool cohort equations into routine guidelines will also be good to inform and influence guidelines, especially for obstetric and cardiovascular guidelines in Kenya. And we'll also be able to target preventive strategies in addition to the life essential aid that have been put in place by the American Cardiac Association. So this is a very important aspect that we're going to look at. So onto the methodology. So the study design, this is a secondary analysis that is nested within a 3-year prospective cohort study, which was done by Alfredo Sotin KNH, that was looking at the prevalence of metabolic syndrome in postpartum women, both who had HDP as well as gestational diabetes in Kenya. So in terms of the setting and the population, I'll be using a cohort of 200 eligible women who were in the parent study, and I'll just be focusing on HDP and normal pregnancy outcome, and were followed up for 24 weeks postpartum to up to 3 years. But from my study, I'll be looking at the women who have complete records, and I'll be focusing on the baseline of 6 months or 24 weeks postpartum to 24 months postpartum, just to make sure we have a good follow-up period. So in terms of the procedures, we'll use this baseline clinical history to be able to divide or put the women into 2 arms, those who have HDP and those without. And after that, we'll be able to take like the history of diet, physical activity, income, residence, as well as occupation at the different time points. And we'll also look at other measurements in terms of their blood pressure, their BMI, and their lipid profile at 6, 12, and 24 months postpartum. So on to the next slide, my primary exposure will be the prevalence of HDP, and this is defined as women who specifically have gestational hypertension or preeclampsia from hospitalization and outpatient records, or where they have 2 average blood pressure readings that is greater or equal to 140/90, and they shouldn't have any target organ dysfunction after 24 weeks gestation and preceding 12 weeks postpartum. My secondary exposure will just be the social determinants of health. So I'll be looking at the education level, their income, where they live, as well as the social and community context in terms of the household size. And moving on to outcome of interest. So we'll have the lifetime predicted ACVD risk score, which is given by the American College of Cardiology and American Heart Association. So we'll be computing various aspects, which I'll talk about in the next slide. But in terms of the stratification, we'll divide these women based on high risk, having a greater than or equal to 39% and low risk at 39%. So on the next slide, you can see how the tool looks like. So this is we just use the tool from the website. So you find that if you have a female on this, so if you have a 30-year-old female, you'll input the characteristics there. And then for race, because this is a Kenyan population, we'll just be focusing on other. And in terms of the labs, you can see we can put the indices that we want, as well as the personal history. And on the top right, we can be able to see the lifetime ACVD risk, which gives a 39%. And when we give any preventive treatment, we can see that the risk comes down to actually 8%. So they have categorically said on the left side that we'll not be able to calculate a 10-year risk because the patient is less than 40 years of age. Yes, so we can go to the next slide. So in terms of outcome of interest, for the secondary outcome, I'll also be evaluating changes in cardiovascular risk factors at the different time points. And so I'll be looking at my blood pressure, my total cholesterol and HDL cholesterol, BMI, as well as physical activity and diet. And we can proceed to the next. In terms of potential covariates, I'll be looking at contraceptive history, the maternal and antenatal profile, HDP, smoking, as well as alcohol use, and any family history of any condition in terms of hypertension, CVD, and venous thromboembolism. In terms of my analysis, I'll be doing descriptive statistics first, where I'll be trying to summarize continuous and categorical variables, which we presented as mean plus or minus SD for normally distributed data, and by median and interquartile range for non-normally distributed variables. Onto the inferential statistics, I'll can go to the next slide. For my first aim, I'll use a chi-square and independent t-test to determine the differences and associations between HDP as well as the ACVD risk scores. And for the second aim, I'll be doing a multivariable linear regression model just to evaluate the associations between social determinants of health and the changes in cardiovascular disease risk factors at baseline, 12 months, and also 24 months postpartum, while adjusting for covariates. So in terms of the power estimation, this is dependent on aim 1. And so with a sample size of 200 women, this will provide 80% power to detect a relative difference of 40% in the primary outcome given a two-sided alpha level of 0.05, assuming an 8% rate of CVD risk in the control group of women with a normal pregnancy outcome. In terms of the limitations that we have for this study, as I mentioned before, the pool cohort equation was developed in the US, and so we want to see its performance outside the US, and it might be highly variable because of the differences in the prevalence of risk factors. And so we want to evaluate that and see how it's going to perform. And also the parent study also had undiagnosed women with gestational diabetes who could have been misclassified as having a normal pregnancy outcome. And this occurred especially during the follow-up period, especially at the 3-year mark during the COVID-19 pandemic period, where the follow-up was not as good because of the restrictions that we had within the country. And so we potentially are looking at probably an overestimation of lifetime cardiovascular risk scores, especially within the normal pregnancy outcome because of the misclassification. But looking at the strengths that we have, this is a novel and unique study that is assessing the lifetime CVD risk scores using the pool cohort equation in a younger and also a postpartum cohort in Kenya. And we'll also be able to determine the influence of social determinants of health factors and looking at the changes in cardiovascular risk factors during the postpartum period. And this will also be able to inform future research on the inclusion of inflammatory biomarkers and other parameters that are very essential, especially for postpartum women, because majority of their pathophysiology and development of CVD is based on inflammation. Yes, so basically in terms of my summary, So the burden of cardiovascular disease is increasing with disproportional prevalence in low and middle income countries, and there's inadequate CVD risk assessment, follow-up, and linkage with medical services, especially beyond the postpartum period. And for this analysis, we aim at evaluating the risk score based on the full cohort equations, and also just looking at the social determinants of cardiovascular health among these women. So I'd like to thank my thesis committee, who've been very instrumental in this thesis, Dr. Sarah, Alfred, and Chris, as well as the CMRTP and RTP, who've been influential in helping me be here. Annette and Kari, thank you so much for your support, as well as the RTP team and my Fogarty fellows. Thank you.
Thank you so much, Floria. That was really great and really interesting presentation. Thank you for doing that. I see we have one question. I want to encourage us to, if you have any questions, we will take care of that at the end. We will answer the questions at the end. So please keep putting the questions there. But thank you, Floria. So it is now my pleasure to invite Dr. Saate we'll go on to the next presentation. Dr. Saate is a cardiologist and junior faculty at the University of Washington. She also has a master's in science in health metrics at the from the University of Washington. She's a Fogarty Fellow in Nairobi right now, currently completing her Fogarty Fellowship in Nairobi. And she also has some supplemental funding to launch a multimodality cardiac imaging study investigating the effects of HIV and tuberculosis on subclinical cardiovascular disease in East Africa. So it's really my pleasure to invite Dr. Saate, who's also part of the Global Cardiovascular Health Program team. Thank you.
Thanks for that introduction, Sarah. And I'm going to go ahead and share my screen. Can everyone see the slides okay?
Yes, we can.
All right. So I'll be talking today about the Saate study, early structural heart disease, HIV, and tuberculosis in East Africa. And I'll be discussing some progress and challenges. Okay, I have no disclosures. So my goals today are to briefly present the motivating background literature for the Saate study in Kenya, and briefly summarize the scientific aims, outcomes, and exposures of interest. But I'd mainly like to focus on an overview of study workflow and logistics and summarize current progress in launching the study and associated challenges. So I wanted to start by summarizing the current literature on the effects of HIV on cardiac structure and function. And I've stratified this by myocardial cardiac muscle versus coronary or vascular phenotypes, and contrasting data from high versus low income or developing countries. So what we know about HIV is that it causes myocardial damage as assessed by multimodality cardiac imaging, including MRI and echocardiography. The mechanism is thought to be mediated by systemic inflammation and immune dysregulation despite viral suppression. And it's thought to lead to myocardial infiltration, steatosis, and fibrosis, which ultimately leads to left ventricular hypertrophy as a structural change, and systolic and diastolic dysfunction and cardiomyopathy as a clinical consequence. When you look at this phenotype in data from developing countries, most of those are based on echocardiography, and you find that this phenotype is actually the same in both settings. So specifically what's been measured is subclinical systolic dysfunction by echo, and then there's also evidence of increased left ventricular mass, which ultimately leads to hypertrophy. However, when you look at the coronary phenotypes, the vast majority of data on atherosclerotic cardiovascular disease is from high-income settings, likely due to the relatively high resource and expensive modalities needed to assess this. And accelerated atherosclerotic cardiovascular disease is present in individuals with HIV in all anatomic distributions. It's thought to be linked to heightened immune activation. There's high-risk plaque morphology that's been described, as well as increased cardiovascular events, including myocardial infarction, stroke, and peripheral arterial disease. However, there's very limited data But limited anatomic studies from East Africa suggest that HIV may not be a risk factor for atherosclerosis in this particular setting. So we're actually seeing a geographic divergence in these phenotypes, the myocardial phenotypes being consistent in HIV, but the coronary or atherosclerotic phenotypes being a little bit different. So this, many of you may be familiar with, is actually Chris Longnecker's study. I think he's on the call today. And it's the Ugandan study of HIV effects on the myocardium and atherosclerosis, or MUTIMA. This was a cohort study of 200 participants, 100 living with HIV and 100 controls. And it utilized multimodality cardiac imaging, but I'll be focusing on the cardiac CT data today. So this is an example of a three-dimensional reconstruction of a cardiac CT, and then these are cross-sectional imaging. This is the left anterior descending, and then just various cuts of the imaging. And basically this is a contrasted study, so you can look for both plaque burden and plaque morphology in the coronary arteries. This is a pretty sensitive test and comparable to the gold standard, which is invasive angiography. So this cohort really enriched for individuals with cardiovascular risk factors in Uganda, including older age and at least one metabolic risk factor, including diabetes, hypertension, dyslipidemia, and weight. The baseline study was cross-sectional, and there was a year 2 longitudinal study. So at year 1, individuals had a baseline risk factor assessment, inflammatory markers, and a coronary calcium score. So what I showed you earlier was coronary angiography with contrast. A calcium score is a non-contrast study. And you can see the breakdown of participants. In year 2, there were 132 participants who returned for follow-up, and 68 were lost to follow-up. And one of the analyses I did was to look at the presence of any coronary artery disease or any coronary atherosclerosis. And in this preliminary analysis, what we found is that in year 2, they had coronary artery angiography with CT. And I did both an available data analysis and a sensitivity analysis, adjusting for these risk factors and for HIV status. So the year 1 results were published a few years ago. And as you can see, the baseline cohort characteristics, they're very metabolically burdened. About a third are classified as high risk ASCVD by the pooled cohort equations. And as you can see, hypertension and abdominal obesity are the most common or highly prevalent risk factors in this group. And what's interesting is that this particular paper from 2019 actually compared coronary calcium in the Ugandan cohort, both with and without HIV, with a similar cohort in Cleveland, Ohio, so an American cohort. And what's interesting is that the blue here represents the absence of coronary calcium. So a 0 coronary calcium confers you could say a decreased risk for atherosclerotic coronary events in future. And you can see that the Ugandan cohort is actually 91% of them had 0 coronary calcium compared with 50% of US participants. And when you look at the individual risk factors, actually, other than smoking and age, neither HIV nor the other traditional risk factors were really predictive in this small cohort. I think we may be running short on time, so I might step through this one a little bit quickly. But in year 2, I looked at the presence of coronary atherosclerosis based on CT angiography. So this is a more sensitive test than coronary calcium. So interestingly, the prevalence of individuals with any coronary artery atherosclerosis was only 17% in this cohort. That means 83% of them did not have any coronary atherosclerosis, which is really interesting in a population that's actually enriched for the risk factors that are causally related to coronary disease, at least in literature from high income settings. And we looked at some inflammatory markers, and I'm going to skip to the punchline here just to save some time. But what we found is that the inflammatory markers traditionally associated with atherosclerosis, and in particular interleukin-6, were inversely associated with coronary disease among Ugandan males. So there were both sex differences and an inverse relationship with coronary disease that was unexpected. And of course, this is a small sample size with a large number lost to follow-up. And as you can see, there are resultant large standard errors. So there's certainly a need for validation of these findings in additional and larger East African cohorts. So that brings me to the Asante study in Kenya. So the goal is to expand the study design in Uganda, and ultimately pool the data with Uganda so that we can increase the sample size and increase the power. So the design is mirroring Mutima with distinct aims and hypotheses. And the aims are to define the prevalence of and risk factors for subclinical coronary atherosclerosis, as well as subclinical myocardial dysfunction, using CT coronary angiography and echocardiography or cardiac ultrasound, respectively, and ultimately to compare those phenotypes with other East African cohorts to see if the relationships that we observed in Uganda actually bear out in Kenya as well. And the hypotheses here are actually based on what we observed in the Ugandan study, which is that the traditional risk factors in HIV will actually not be associated with coronary atherosclerosis in this population, but they will be predictive of myocardial disease. So it's a similar study population to Mutima, inclusion and exclusion criteria. And in addition to these core exposures of interest, we're also collecting data on behavioral and psychosocial factors, including sleep and smoking, as well as infections, including tuberculosis ascertained by interferon gamma release assays. And we're banking peripheral blood mononuclear cells, inflammatory markers, and whole blood RNA for future transcriptomic studies. These are some of the imaging outcomes. I'll just focus on the primary here, because HIV and also traditional risk factors are very much related to early diastolic dysfunction and left ventricular hypertrophy. These will be our primary outcomes. And for the coronary CTs, we will look at the presence of plaque, just because it's so rare in the Ugandan population that we will probably run into very small numbers if the phenotype bears out in Kenya as well. So instead of looking at obstructive disease or degree of disease, we're just looking at the presence of atherosclerosis in the coronaries. So I just want to walk through a quick map of the study. So this has been a really good learning experience for me to just understand the anatomy of participant flow here in Kenya and think about where to position people and where to draw samples and where equipment needs to be. So we'll be recruiting participants from the HIV Comprehensive Care Clinic at Kenyatta National Hospital. And we'll be recruiting control participants from the HIV voluntary testing centers, individuals who have tested negative that same day. So they will be screened at these settings, and then they will walk over to the cardiology department where they will undergo an electrocardiogram, a 12-lead electrocardiogram, as well as echocardiography or cardiac ultrasound. And then they'll also get blood drawn. And I'll start with the patient flow first, and then I'll go back and talk about the data flow. But from cardiology, they will actually be transported to Coptic Hospital, which already has a CT coronary angiography protocol in place, and they'll get their CT, and this will all be done in one visit. So the phlebotomy samples actually will end up going to a few different places. So for TB testing and stored whole blood for transcriptomics, they will go to our partner Lancet Laboratory, which is not too far by courier. The plasma and the peripheral blood mononuclear cells will actually head to just be walked over to the University of Nairobi Pediatrics Laboratory. So this is kind of the outline of the study, and it's been really helpful mapping this out just to understand where to put resources and where to anticipate problems. So I did just want to go over briefly the timeline of how long this has taken to put together and what we still have ahead of us. So we started in July 2022. This is when I started the initial IRB submission for UW and Kenya, and also started discussions with proposed partner imaging and laboratory sites, so Coptic and other laboratory sites as well. And in blue, I've just highlighted what I think I feel are the wins or the achievements so far in the timeline. So the Kenyan IRB submission modifications and approval came through in November 2022, as well as study approval from stakeholder departments like cardiology and the CCC HIV clinic. And around this time, we had to figure out how to get research funding from UW to Kenya. And By January, we had drafted service contracts for coronary CT, as well as initiated staff hiring through UW Kenya, which is the global assistance program that helps us manage funds here. Unfortunately, in February, the partners we had previously talked with weren't able to support some of our lab collections, so we had to draw up contracts with new laboratories. Luckily, Lancet Labs and the University of Nairobi Pediatrics Lab were able to support us. We also moved the echo machine to our dedicated study room in cardiology, which we were able to secure to facilitate data collection and to streamline patient flow, which I think is really important when you're asking a participant to commit several hours to all of these data collection and studies. And shortly thereafter, we negotiated and drafted new contracts for laboratory services with Lancet Labs. In March 2022, we had, this should say 2023. We had some challenges with administrative support. I brought over some supplies from the US. And now we're in April, so we've been reassessing and reallocating the budget for administrative support and new study staff. We've finalized service contracts for laboratory and imaging services and initiated the hiring process to put together the study team. And hopefully by June 2023, which is the end of my Fogarty Fellowship, we'll have established the study team and initiated trainings and stakeholder trainings as well, and informational sessions. And hopefully we'll start recruiting perhaps in August. It might take a little bit longer than that, but I think what I've learned is that it's really important to have the infrastructure and workflow set up in place. So in order to be adaptable and flex to any challenges later. So further anticipated challenges. So I've been on site this year, but obviously the end of the Fogarty Fellowship is rapidly approaching. So I think communication issues, once no longer on site, we'll have to set up regular meetings. And then the local study team, like Drs. Knuthia, Dr. Saate, who I believe is on this call, are going to be really key in moving the study forward. And of course, with all human subjects research, delays in recruitment, data collection, especially when we're asking participants to commit so much time, will be a challenge. So I think having a very clear workflow, knowing the anatomy of the study, and then flexing and adapting to change the workflow based on progress and challenges. And finally, I think the hope with this study is not just to collect data and not just to test these hypotheses, but to help develop and support cardiovascular disease research infrastructure in this setting and ultimately in other settings across the world. And so the cardiac imaging data quality and reproducibility will be very important. And then we are also involving local cardiologists as stakeholders and collaborators. So I'll stop there. I just wanted to acknowledge my mentors and collaborators. Everyone on this list has been really wonderful and supportive, and acknowledge my funding sources here.